So this is the standard surgical approach to hypertrophic cardiomyopathy. It's been around for decades. Dr. Morrow really perfected it. At the NIH, you do a sternotomy, you go through the aortic valve, and you use a blade to resect the subaortic structure. And it's a time-proven method. It's been adopted widely and changed over the years, but basically it's the same procedure. This is a very important slide, and I actually show this to patients when they come to see me in the office, and that is that surgery for hypertrophic cardiomyopathy, which is a myectomy for the med students and residents in the room, not myomectomy, as people say, it's a myectomy, actually works. If you look at this survival curve, obstruction without myectomy has a very poor survival, and if you do a successful myectomy, it restores them to the same survival as a patient with hypertrophic cardiomyopathy that does not have obstruction, which is roughly the same as the general population with optimal medical management. So the procedures work. So I asked a question a few years ago, are there things that can be improved upon this operation? You're finding a theme with me. I'm always looking to get better, to do better. So many patients need concomitant work on their mitral valve. It's only about 5 to 8% in various studies, although what drove me into this work is, in addition to referrals, was seeing a fair number of patients come back after a standard Morrow procedure, extended Morrow, with mitral valve problems, and sometimes aortic valve problems where the aortic valve got damaged during the procedure. The incidence of recurrent mitral valve disease is significant, I think due to damage of the anterior leaflet with SAM, or systolic anterior motion of the valve, for those of you who are not cardiac surgeons, needs for less invasive approach. And even at the best places in the world that do the Morrow procedure, there is recurrent obstruction, often because of the fact that the subvalvular obstruction is very deep in the ventricle. And for any of you who've attempted to do this procedure, it's very difficult to see it through the aortic valve.